So, good morning and welcome to today's Ethnic Media Services Zoom News Conference, co-sponsored by the Blue Shield of California Foundation. This is our first briefing of 2024, a very consequential year, both for health, for politics, and so much more. I'm Sunita Sarabji, EMS's health editor and the co-director with Pilar Marrero of our Friday news briefings. The US is currently facing a simultaneous rise in COVID-19, the flu, and respiratory syncytial virus, RSV cases, what some medical experts call a tripledemic or a tridemic. The surge of respiratory illnesses threatens to burden an already overstretched healthcare system with possible lapses in care for vulnerable communities. Experts this week will discuss the unprecedented rise in infection of all three illnesses, the origin of JN1, symptoms, causes, prevention, and treatment, and why vaccines and masks remain very necessary. Our speakers include all familiar faces: Dr. Benjamin Newman, the chief virologist of the Global Health Research Complex at Texas A&M University, Dr. Manisha Nuaskar, a pediatric pulmonologist at Stanford Children's Health, and Dr. Perez, the chief medical officer at South Central Family Health Center in LA. We ask speakers to speak slowly for our interpreters in Spanish, Mandarin, and Korean, and we ask reporters to enter questions in the chat, which we will address following each speaker as time allows. Our speakers are also encouraged to answer questions in the chat throughout the conference. We will send a video of today's briefing and expanded bios with contact information for each speaker to all participants later today. We now start our briefing with Dr. Jose Perez, who will present an overview of all three illnesses. Welcome, Dr. Perez.
Thank you. Thank you. It's a pleasure and a privilege to be here with you guys again. Thank you for having me. I am a chief medical officer with South Central Family Health Center. I am a family medicine doctor by training, and I'm still a practicing physician. I see patients 2 days out of the week. So I am in the middle of taking care of patients and being exposed myself and also taking care of patients with these illnesses. I apologize. I'm joining from my phone. My computer played tricks on me, so I'm going to have the folks over there go through my slides. I have only about 7 or 8 slides, so it shouldn't take too long. And I would like to give you sort of an overview of what the diseases are. I know that the experts will contribute a lot more to the basic knowledge, and give you sort of an overview of what we see from a public health standpoint. Go ahead, next slide. Next. One more. So there are more than 100 different viruses that cause upper respiratory infections. Those include COVID-19, RSV, and the influenza virus. Just a reminder that COVID-19 is also known as SARS-CoV-2, so you may see that in print or in other forums. Next. So RSV is a respiratory syncytial virus. It's interesting. This virus has been around for a long, long time. I remember learning from it from medical school over 25 years ago. But it keeps coming back, and it also causes problems for young children, which you will learn a little later. Go ahead. Next. The influenza virus, also common flu, the flu virus. It's a virus that most everybody is sort of familiar with. Interestingly enough, just for everybody, Having the flu is interchangeable with having a cold. In medicine, it is not the same. Having the flu is being specifically infected by the influenza virus, but in popular culture and in the public terms, it is used interchangeably. Just make sure that we all understand that having the flu is not the same as being infected specifically with the influenza virus. Next. So most of these viruses cause upper respiratory infections, um, and those include symptoms in the nose, the throats, the eyes, along with what we in medicine call constitutional symptoms, such as fever and muscle aches. All three viruses, next, all three viruses can cause lower respiratory infection, and that include infections of the bronchial tree and lungs, which can lead to bronchitis and pneumonia. Next. Next slide. So how do we get these viruses? All three viruses invade the human body by coming in contact with body fluids from an infected individual. Next. All occur more frequently during the wintertime when people are forced to be more indoors due to inclement weather and during holiday celebrations. Coughing and sneezing without covering the mouth or nose from an infected individual leaves mucus particles in the air and on surfaces such as counters, eating utensils, doorknobs, etc. An uninfected person will then touch these areas and touch their own faces or breathe the air around the infected person, and the virus enters the body through the nose or the mouth. Next. It is very difficult to tell which virus is affecting the patient based on symptoms alone. Next. Most infected people will have what we call the cold, will feel sick for a few days, will require only what we call supportive measures, rest, lots of fluid, some chicken soup, ibuprofen for pain and fever, and sometimes a cough syrup is all that is necessary to get the patient through the symptoms. That can last up to 7 to 10 days. Next. So you're gonna click quickly here. So here are the symptoms of COVID. Everybody pretty much know it: cough, sore throat, runny nose, fever, tiredness, muscle aches, shortness of breath, and the one that is particularly for COVID is the loss of sense of taste or smell. When we compare that to RSV, what do RSV cause? It causes cough, sore throat, runny nose, fever, shortness of breath, an increase in respiratory rate, especially in children, wheezing, and retractions. When we compare both of these to the influenza, you can see what the pattern
Dr.
is.
Perez, I'm sorry to interrupt. Could you just explain retractions in children?
Sure. I was actually going to let the pediatrician do that, but I can do that. So when you look at a very small baby at their chest, when they're breathing and they're having difficulty breathing, you see that with every breath, you see the outline of the ribs. That means that the patient is using those, what we call intercostal muscles, to be able to expand their chest and take breath in. And that is a concerning sign when you are seeing a small child that is having trouble breathing. So, so as you can see, this is the reason why it is very difficult to tell what kind of virus you have based on symptoms alone, because they all share sort of the same commonalities of cough and runny nose, fevers, and even shortness of breath. Next. So epidemiology, who is at risk? Everyone is at risk for a URI. If you're human and you're alive, you can catch it. The problem is that some of us will go on to develop what are called lower respiratory infection. And as I said before, this can include pneumonias and bronchitis. Who are the folks that are more at risk? Those who suffer from lung diseases like asthma, COPD, and obesity. We know now more firmly that obesity does impair our ability to breathe normally. So obesity, it is a risk factor for developing, especially with COVID, developing more severe disease. Those who are immunosuppressed, diabetes, very prevalent in the Hispanic community, affects your immune system. Diabetic patients who are not controlled, their immune system does not work well, and they are predisposed to getting infections more frequently and more severely. HIV is another disease that renders the patient immunosuppressed. Those being treated with cancer, chemotherapy, radiotherapy, are among all the other folks that are considered to be immunosuppressed. For RSV, risk factors are infants younger than 12 months, premature babies, and the elderly, 65 years and older. Next. So what's going on in LA County? I downloaded this yesterday. If I can bring down to the bottom, you see the positivity rate for all three of these diseases. The green line is influenza, the blue one is RSV, and the yellow one is COVID. As you can see, influenza is the one that is on the rise more acutely than the other two. COVID is increasing, but the rate of increase is not as frequent and it's not as steep. And as you can see, RSV, we sort of had a small little plateau around the end of November, and it seems to be trending down in LA County. Next. One more. So this is a snapshot from the state of California. If I can bring you to the last column, this is the positivity rate for California, which is at 9.6% and is on the increase. And the testing for influenza is also on the rise. It's interestingly that you can see the line sort of coming down in January and then going back in October. This is because this is what we call the flu season, which is seasonal, and we know that it happens almost every year. Next. This is also a snapshot of what's going on in the nation. This is how many tests were performed across the nation, and the lines represent the positivity rate. At the bottom, where you see the numbers is the last two numbers is the. For example, the last column is week 51 of the year 2023, which is the penultimate week in December. So there were about 6,600 tests for COVID, and it had a positivity rate of about 17%. So out of those 6,000, somewhere around 800, 900 people turned out to be positive. Similarly with RSV, as you can see, it's sort of nationwide, it sort of peaked on week 50, and now it's sort of it came down in week 51 with a positivity rate around 12 to 13%. Next. So what do we do? The lessons that we learned in COVID, are still very critical and are still things that we can do to keep ourselves, your family members and patients safer. Watch your distance. We know that 6 feet or so, if anybody's coughing or sneezing, it doesn't travel as far as more so than 6 feet. So staying away from someone who seems to be sick about 6 feet will help minimize your risk. Wearing a mask. Remember that the virus, as I presented earlier, comes through your nose and mouth. So if you cover your face with a well-fitting mask, a surgical mask, or one of the end masks, that also is helpful. And remember that washing your hand is also extremely important. If you feel sick, stay home. Just rest, allow your body to heal, and that way you do your thing to prevent your own community to get sicker. And for just get vaccinated. Vaccines are still extremely important. Next. Uh, as far as COVID vaccines, there are no more free vaccines. The federal government ended their free vaccine program back in May of last year. The responsibility of all vaccines goes back to the health plans. So your health plan may have a copay. In the state of California, we have a vaccine program called VFC, Vaccines for Children, and VFA, Vaccines for Adults. So any patient, any individual who has Medicaid, in California we call it Medi-Cal, can get these vaccines for free through their Medi-Cal provider. Places like us, community health centers. The COVID vaccine, it's available to all people 5 years and older. These are the type of vaccines that are available. Everybody sort of kind of remember and knows, but Pfizer and Moderna, which were the leading ones that we got during the pandemic. There is a newer vaccine called Novavax, which works a little different than the Pfizer and the Moderna one. And the Johnson & Johnson is no longer available. The flu vaccine, it's approved for all people 6 months and older every year. And here the three types that we normally use in our clinic. And lastly, the RSV vaccine is approved for infant 8 months or younger, children 18 to 8 months to 19 who are at increased risk of severe disease, and adults ages 60 years based on risk factors. And the risk factors will include things like asthma, COPD, diabetes, and all the other immunocompromised conditions that I spoke before. So next. So these are where I got my information. If you want to dig deeper, there's tons of data in all these sites that you can sort of peruse at your leisure. So I'll stop there. If anybody have any questions regarding this particular portion, and then I guess I'll come back later.
Yeah, Dr. Perez, we have just a couple of questions for you. Mosin's question got answered by Dr. Newman, but Dr. Newman, I'd like you to share your response live when it comes to your turn, because that was great information. Dr. Perez, how long are we contagious after we start to see symptoms?
Yeah, so 7 to 10 days is what we believe it's when you're contagious, and our virologist will probably give more information. But we know that by the time you exhibit symptoms, you have been infected at least a week or so. It just takes time for the virus to multiply and overtake your immune system before you start getting symptoms. So you don't get sick from one day to the next. It does take time for the virus to grow and incubate and make you sick.
Absolutely. And the other question is, do we stand the risk of reinfecting ourselves? Say we have RSV or the flu a couple of weeks later, do we stand a chance of reinfecting if we're re-exposed?
So yeah, so if you chances are you won't get reinfected with the same virus because your immune system is already aware of it and has developed antibodies against it. And that's why about 7 to 10 days later, in most cases, you stop having symptoms because your immune system has basically learned to fight it. However, if you can get any of these three viruses at any time and even at the same time. So most people who have a cold, so to speak, and then they get over it and then they get another cold, usually it's a different virus that is attacking you, because the COVID, the influenza, and the RSV are not the only viruses that are running around rampant during the winter time. You have rhinoviruses, coronaviruses, adenoviruses, and all other kind of viruses that can sort of cause the same thing.
Thank you, Dr. Perez. Could you please stick around to provide an overview from your clinic after Dr. Newman and Dr. Nuasker present?
Yes.
Thank you. We move on to Dr. Newman for updates on the new COVID subvariant. Dr. Newman, how many times have we had you on with as each subvariant emerges?
There's always a new variant, isn't there? Yeah.
Yes, yes. So welcome, and please tell us about JN1.
Before we start, I would say that it really doesn't matter which variant you have when you're lying in a hospital bed or in a medically induced coma. If any one of these gets through your defenses, there is an increased risk of hospitalization and death. And the vaccines mitigate that. They make it less likely, but it is still very much possible. So let's talk about the new variant. The new one that everyone is talking about is called JN1. And that is an interesting variant because up until this point, we have vaccinated against 3 different strains, and we have driven all of those to extinction, probably through a combination of vaccination and herd immunity. This is the first time that one of those older strains has escaped, mutated, grown, and come back to cause additional problems. So JN1 is a relative of an older strain called BA2.86, and that's essentially one of a descendant of the early Omicron strains. All the rest of that family tree has gone extinct or has mutated into the other strains that we see. But right now, JN1 is about 50% of the cases that are being reported worldwide, and it is growing much faster than any of the other strains out there. So in the past, when the virus was evolving, it would make a mutation, and then it would make another mutation in addition to the one that it had. And so there was a very linear path. And the big challenge was keeping up to date. As long as you're using a vaccine strain that's fairly close to wherever the virus is now, there was no problem. Now, with this new strain, it looks as though the virus has forked, has split. There are 2 very different lineages, and one vaccine does not protect against both of them at the moment very well. There's some protection, but it is relatively little. So it's perhaps not as doom and gloom as I said. So JN1 is not particularly faster growing than the other strains that exist right now. It is, according to some computer estimates and lab estimates, maybe 10% better at growing virus particles. And we know from old studies that the more virus that grows inside you, the sicker you get in general. This new strain is as different from the current vaccine strain as that vaccine strain was from the vaccine strain before it. So that when we get to about 8 mutations in the receptor binding domain, that's the part of the virus that makes contact with the cell, that's the point at which we've been updating vaccines because the vaccines don't work very well. And we are at that point. We are 8 mutations different from XBB 1.5, which is the current monovalent vaccine. So COVID has slipped down to number 7 on the CDC's most updated list of causes of death. But COVID may be feeding in to some of these other categories in the form of long COVID. And I think that's something that is not completely settled and probably needs more work and may not be something that we can ever know for certain. For example, we know that after a case of COVID, for at least 1 year, there's an elevated risk of heart disease and cardiovascular disease. We know that after COVID, there is brain fog and substantial shrinkage of the brain itself in at least one study. And we know that people after having COVID can have long-term lower respiratory complications where it's hard to breathe and just difficult to do anything. And these are the causes of death that are actually a little bit higher than COVID right now. So it's unclear the extent to which long COVID is driving that, but it's definitely worth investigating. The new symptoms reported for JN1 are essentially neurological. They're anxiety and sleeplessness. And those are both things that have to do with your brain. And if you think about it, those are also some of the first symptoms that were ever reported with COVID. Do you remember brain fog? We're using a different word to describe what is essentially the same thing. And it's getting reported because, I don't know, people are doing a word search or something like that and seeing a different term. But it looks as though this virus is very much the same virus as all the ones that came before, just a little bit better at growing and much better at evading immune defenses. I think that's probably enough, unless there are questions.
There are, in fact, a number of questions for you. Could you please answer Mohsin's question live? I can repeat it for you.
Sure.
What are the key characteristics and concerns surrounding the JN1 virus mutation, and how might it affect the efficacy of existing vaccines?
JN1, so people have compared the immunity that you get from either vaccination or natural infection with two of the strains that are currently circulating, including the current vaccine strain. And they found that they are relatively ineffective in the sense of being barely effective against JN1. So JN1 is a virus that is likely to be able to get in despite pre-existing immunity. And I think that's the main reason why it is concerning.
Interesting. Elena, would you like to ask your question live? Where's Elena? I can ask her question for her. There you are.
I'm sorry, barking. So my question, I have two questions. The first one is if the new variant is more dangerous than the previous ones, and if the vaccine works. For example, I got my last vaccine a year ago, and I'm worrying, should I get new one? Thank you.
Definitely, I think we can let the actual medical doctors in the room weigh in on that. But from the scientific perspective, the immunity that you get from the vaccine is certainly helpful. But after a year, the component called neutralizing antibodies that actually shield you, stop the virus from getting in, those are low to gone. And because of the changes in this virus, it actually decreases the time that you have to enjoy that sort of protection. So yes, an update would help. But right now, the current monovalent vaccine is going to be very good against about 50% of the viruses and not very good against the JN1, which is about 50% of the circulating viruses.
Thank you. Renee, does that sufficiently answer your question as well? Okay, all right. So, Henrietta Burrows has a couple of interesting questions. Henrietta, welcome.
Thanks so much, Sunita. Do viruses compete against each other? For example, you mentioned some viruses died out, some viruses seem to merge, and so is there a fight going on? And why is it that the BR2 survived into the JN1? And also, you mentioned brain shrinkage. What part of the brain is involved that might shrink the most? And is this permanent damage?
Yeah, so the studies on brain shrinkage that I've read were looking at a very coarse level. So they were just looking at the total brain volume of gray matter, and they did see shrinkages. They were not able to conclude whether that is permanent, but most brain damage does have lasting effects of some sort, I would say. And this appears to be brain damage that's kind of everywhere. They didn't notice particular shrinkage in one place as opposed to another. It seems to be connected to the blood vessels, and yeah, there are lots of blood vessels in the brain. I think I
And the
missed
question
the other
about
half. Yeah.
about the viruses competing.
Oh, viruses compete with other viruses more than they compete with anything else because there are only so many lungs to go around, and the virus has to be in one of them or else it is extinct immediately. Yeah, they are
Do they
very
fight
good.
each other?
Not directly, but viruses can interfere with each other. And once a virus gets into a person, it will provoke an antiviral response that makes it difficult for a second virus to get in. It's a very first come, first served kind of system.
A great question, Henrietta. Thank you.
Thank you, Sandra.
Of course. We should move on. There are questions for you, Dr. Newman, but we need to move on to Dr. Manisha Nuaskar, a pediatric pulmonologist at Stanford. Dr. Nuaskar will talk about RSV. Welcome back.
Yeah, thank you so much for having me. So I have a few slides. If Jessica, if you don't mind sharing them. Thank you. So because I'm a pediatric pulmonologist, my brain definitely works more towards children, although RSV is also seen in older adult population. So I'll try my best to be inclusive of all age groups during my presentation. Could you move on to the next slide? Thank you.
There we go.
Okay, thank you. So, I guess my slides are somewhat repetition of Dr. Perez's slides, but a little bit more focused on RSV. So, typical RSV season in the US, in North America, is essentially October through March, although I would say that in last couple of years, since the COVID pandemic, it has been a little bit more variable. Like we have seen early start of the RSV season and lasting longer also, but this has been traditionally sort of a fall, winter, October through March. And as Dr. Perez mentioned, typically it's just a regular cold, especially in older children and young adults. And you typically have the regular runny nose, cough, fever for a few days, and then you get better. But in infants, and especially premature infants, it tends to be a little bit much more severe disease. And so if in the first year of life, you tend to have a little bit more like lower respiratory tract illness, and the presentation may be similar, meaning children or the infants may present with some runny nose, fever, but they can progress to irritability, poor appetite, and then they start having trouble breathing, wheezing, their oxygen levels go down, they start breathing really fast. And as Dr. Perez said, that the physical manifestation is that you can clearly see the baby breathing really fast and pulling all the muscles to breathe. And so you can see retractions, nasal flaring and all that. So that is a sign that the baby is having severe difficulty, and probably the oxygen levels are low in the body. So that would be the situation where the babies need to be seen in emergency room, and a lot of times they need to be admitted to the hospital. In older adults, again, it can be based if they have a lot of underlying conditions. And again, Dr. Perez mentioned that if they have diabetes, they have asthma, COPD, those adults, the high-risk adults, are also at risk of having lower respiratory tract infection, which can present with difficulty breathing, wheezing symptoms, and they can develop pneumonia. Next slide. So what we know about RSV is that it's a leading cause of bronchiolitis in children. And I had looked up some CDC data for RSV in children less than 5 years old. So it results in 2.1 million outpatient visits annually. There are about 58 to 80,000 hospital admissions annually and 100 to 300 deaths. And this is all in children below 5 years of age. And among these, infants below 6 months are at the greatest risk for hospitalization. And also, I mean, among those infants, we see that the highest morbidity or mortality is seen in infants who are born premature. And also immunocompromised individuals are at extremely high risk for morbidity and mortality. Next slide, please. So RSV is a very common virus that circulates around your fall, winter months, and nearly all children, and in fact, you know, everyone is infected with RSV before their second birthday. But not everybody shows that severe disease. And it's basically this younger you are, the older you are, or your immune status kind of defines how severe it's going to be. And I'm not going to spend too much time on how it spreads because Dr. Perez already mentioned, but basically it's through contact and droplets. So if you have a sick person in the house, it can, you know, if you cough and sneeze of an infected person can cause touching surfaces, which contain infected secretions. And then, you know, little children, especially like, you know, a toddler does not know, they will touch things and then they will touch their nose or eye, rub their eyes. And that's a very common way of getting RSV through your nose, eyes in a toddler who is going to a daycare setting or school. And what we know is that RSV virus can survive for several hours on hard surfaces. So, you know, you have to be really, you know, on top of cleaning surfaces if you really want to have good prevention. Right now, there are no specific antiviral medications available to give to children who have RSV illness. The treatment is mostly supportive. So typically, you know, it involves like if you have fever, you take some Tylenol. In younger infants, because they tend to have a lot of trouble breathing when their nose is really clogged up and they haven't quite figured out how to breathe through their mouth. The most common sort of advice your pediatrician will give is that making sure that you're suctioning the nose of your infant on a regular basis to relieve that difficulty breathing. Also making sure that they're feeding well and making sure that they're getting extra fluids, and rest is important also for recovery. For severe illness where you have trouble breathing, your oxygen levels are low, typically hospital admission is required. And in the hospital, basically the treatments can range from giving IV fluids for dehydration, giving oxygen supplementation. Some children end up needing more involved treatments, including mechanical ventilation, intubation. Next slide, please. Yeah. So since we don't have any good sort of antiviral medication, I mean, mostly prevention is the best treatment for RSV at this time. And since we know that it sort of affects the extreme age group, so infants and older adults, that's where our focus is to kind of do preventive measures, especially for that age group, by giving them vaccines and all that, right? Now, we know about a vaccine, pelivizumab, which is also called Synagis commonly. And these are not real vaccines. These are actually antibodies that are given to babies to prevent them from getting severe RSV disease. Synagis has been around for greater than 25 years, but it was only indicated for very, very specific group of infants in their first RSV season. So premature infants born less than 32 weeks of gestational age, babies with congenital heart disease, neuromuscular disease, cystic fibrosis. Those were the typical indications for Synagis. And so it was not commonly available to every infant who was born. And these were monthly injections because these were actually antibodies that were passively given to prevent RSV disease. So the babies would get monthly injections through the RSV season, typically October through March. Next slide, please. But now we have this year, FDA approved a new sort of, again, this is not exactly a vaccine, it is also a passive antibody. It's called nirsevimab or Beyfortus, and it's now recommended for all infants. So whether they are premature or not, they're full-term infants, all infants below 8 months of age, born during or just before the start of RSV season, are eligible to get this particular vaccine. And because we also see severe RSV disease in older children, older meaning I would say more up to 2 years of age, they have, especially who are at high risk for severe disease who have underlying conditions, then this vaccine is also eligible or recommended for children with high risk conditions 8 to 19 months of age. And so in the trials, they found that Beyfortus or nirsevimab was pretty effective, almost like 79–80% in preventing RSV-associated lower respiratory tract infection, about 81% effective in reducing hospitalization, and 90% in preventing ICU admission. So pretty effective, and something that is recommended for just this year. And the problem with nirsevimab, what we have found is that implementation has been somewhat difficult because of cost barrier, because it is a costly sort of medicine that's not free right now, but it is available through vaccine for children, as Dr. Perez mentioned. But the other problem has been that the supply has been limited from the manufacturer, so it has not been widely implemented. So we are still seeing a lot of cases of RSV. Next slide, please. So now they have also come up with vaccine. Now this is true vaccine where they're actually giving antigen or the kill virus and to produce antibodies, just like your traditional vaccines. And these are licensed for use in adults greater than 60 or above. So there are two types of RSV vaccines, and it's single dose given before fall winter season, just like your flu vaccine. And again, very effective. They reduced the studies showed that they reduced the lower respiratory tract infection by almost 82% during RSV season. The other one was also 89% effective. Next slide, please. Now, one of these two vaccines, which is Abrevzo RSV pre-F vaccine, is also approved to be given to pregnant women in their third trimester. So 32-week through 36 weeks of gestational age during pregnancy, women can get RSV vaccine, which will protect their newborn babies against severe RSV disease. And again, it was the clinical trials showed that if moms of pregnant women received, then it reduced the risk of severe RSV disease by 82% within 3 months, and by 69% by 6 months after birth. And a risk of hospitalization also significantly decreased. So again, this is something that's available for pregnant women, but only through third trimester. That was all I had to say.
Okay, fantastic. There are a number of questions for you, Dr. Neuosker. You had mentioned bronchiolitis. Is bronchiolitis a chronic condition, and will the child have to use an inhaler daily throughout the course of their lives?
So bronchiolitis is more of an acute condition. So it's a condition where your bronchial tubes get inflamed and swollen. And so it's a type of lower respiratory tract inflammation in babies. So it's more an acute thing. So while they have it, they are having the symptoms of wheezing, difficulty breathing, low oxygen levels, and it does get better over time. Like, some babies will be sick for about a week or a couple of weeks with the symptoms, and then they get better. But what we have also found is that babies and so infants and toddlers who get infected with RSV, and especially if they have risk factors for asthma, like they have family history of asthma, or the infants themselves have food allergies or just the risk factors for asthma. And if they get RSV, they tend to also have risk for repeated wheezing episodes with future viral infections. So it doesn't cause chronic wheezing, but it can cause repeated wheezing episodes in some high-risk infants.
Absolutely. We are seeing an uptick in adult infections, people that are not over the age of 60 yet, but definitely there. Would you recommend getting vaccinated even in people that are not 60 plus?
So right now, the CDC or the recommendation is only for 60 and above. It has been approved only for 60 and above. I think, in future, they may expand the recommendation to include other age groups, especially if they have high risk conditions like asthma or diabetes or something. But the reason I think the 60 and above is right now included in this recommendation is because they are the highest risk group, and they are the more likely ones who get pneumonia or get hospitalized, right? So otherwise, it's mostly a regular common cold for most of the healthy children and young adults.
Okay, and a good question from a reporter. Are there demographic groups that are particularly vulnerable to getting RSV? And are environmental factors a contributor to healthy recovery? Smog, air pollution, that sort of thing.
Yes, so I know. So we do see that there are some high risk population. People who live in crowded facilities or in daycare settings, it tends to happen more. Certain ethnic groups are also a little bit more likely. We know that sometimes Native Americans and Alaskan natives, they can have a little bit more severe disease, and that's why those groups are more vulnerable, and we recommend definitely, taking precautions and vaccines to those people. Now, I think environmental conditions are always a big factor in how you respond to a virus and how you recover. So I don't think there's anything specific for RSV, but in general, if you live in highly polluted environment or a very in an environment where there are a lot of people in a small space, right? Then you are more likely to have contract the disease if you don't have enough means to get good nutrition or good medications, or if you are not able to see a doctor, or so those people are always at highest risk of having more severe course. But this is not specific to RSV. It is probably across all viral infections or all illnesses.
Thank you. Aliyah Lee has a question on COVID for you, Dr. Nuasker. Aliyah, do you want to ask your question live? I can ask it for her. For children 3 years old who already took the bivalent booster, the first dose, and the newest COVID-19 vaccine, second dose, do they need to take the third dose?
And so the new dose is recommended. The monovalent is, we recommend that for children, yes.
Okay, and Henrietta has a question for you. Henrietta, please ask your question.
Thanks, Sunita. This is a conversation that really hits home for me because I lost an infant daughter decades ago who was 4 days short of 6 months old. And I was wondering how long ago RSV was identified. And it seems it's a vaccine. I'm sorry, it's a virus rather than a bacterial infection, or is it? Because I was told she died from a viral infection and found I had been lied to and it was a bacterial infection. So I'm wondering what the difference is.
Yeah, so Henrietta, I'm really sorry to hear about your child passing with it sounds like either virus or a bacteria, and that's very unfortunate. And, unfortunately, this is still an ongoing thing. Like we see a lot of infant deaths with bad viral or bacterial pneumonia. So what I can tell you about RSV is it's a virus, and I don't know exactly when it was discovered, but I believe it was probably like at least in 60s and 70s, and probably Dr. Newman is more familiar with when actually people came to know about this virus. But it's been going on, like the virus has been circulating for a number of years. It's just that we have now been able to, as I said, that we have identified that infants are really, really the high-risk group. And among them, premature infants and infants less than 6 months are the ones who are the hardest hit with this virus. So there have been efforts to develop antibodies or vaccines for this age group to prevent against significant morbidity or mortality. Now, sometimes what we also find is because this season, also during this viral season, we also sometimes see that you may catch a virus first. So people who, let's say they got influenza or they can get RSV, and sometimes they can get superimposed secondary bacterial pneumonia as well. So your body's immune system goes goes down, and it gives chance for bacteria to start sort of growing and showing their wrath. And so there are secondary bacterial infections are not uncommon with viral infections. We have seen that with RSV, we have seen that with influenza, COVID, every virus. So it sometimes becomes hard to tell, clinically at least, that whether it's a virus that's still causing problem with the patient, or is it also bacteria, or a combination of both. And so if a person, so basically what I'm trying to say is that, it can be a very difficult thing to tell whether it was a virus that caused someone's demise or a bacteria. A lot of times it could be a combination of both.
Thank you, Dr. Thank you, Dr. Nuaskar. So, Dr. Perez and Dr. Nuaskar, I'd like to ask both of you, what are you experiencing at your clinics and hospitals? And then Dr. Newman, I have a final question for you as well. Let's start with Dr. Perez. Dr. Perez, are you seeing a significant uptick of people coming to the clinic with respiratory illnesses? You're muted.
Can you hear me now?
Yes.
Okay. We are fortunate that we have not seen an uptick. In LA County, we're still for COVID, about 13% positivity rate. And this is a question that I have for Dr. Newman. What we experience is an increase in infectivity, but a decrease in virulence, meaning the viruses, with COVID specifically, tend to infect people more frequently, but it doesn't cause as severe a disease. And at South Central Family Health Center, we take care of about 27,000 patients over 9 different sites. And we have what we call a flu clinic in every clinic, where we put our resources into that space to take care of individuals who are having upper respiratory infections and try to get them isolated from the rest of the population. And the report by all of my clinics is that no, we are not having an uptake in increasing in upper respiratory diseases coming to our clinic, which is sort of fortunate. I know that during the COVID pandemic, we did a lot of information and education with our patients. Our patients now, they do use masks more frequently than they ever did. The hesitancy for vaccine, it's still there, but I think those lessons about keeping distance, washing hands, and keeping masks really are making a difference now in this particular epidemic, especially for our own population. But the short answer is no. We are fortunate that we are not seeing more severe disease.
Thank you. Dr. New-Oscar, what are you seeing at Stanford?
So because I'm a specialist, I get to see only people who have more severe disease, unfortunately. But yeah, we are seeing patients getting admitted with severe RSV, bronchiolitis, and also with influenza. So definitely, I mean, the emergency rooms and hospitals are seeing babies and infants with RSV illnesses, yes.
And do you feel your facility is overburdened with such cases?
Yeah, I mean, it is being definitely, the hospitals are full.
Yeah, absolutely. Dr. Newman, a final question for you, and that is, give us the scoop. What are we meant to be looking for in the next round of subvariants? Are there subvariants on your radar that you're looking at that we should be looking at?
Let me check my crystal ball.
We rely on you for that crystal ball.
At every stage in COVID, the virus has done things that are unexpected. Because this is still a new virus and we're still learning about what it can do and how it can change. And with each new variant, we learn something new, but we're always a little bit behind the virus. When it starts making the same mutations again, I suppose we'll know about that. But until then, we just have to do our best. I would say in terms of where we are right now, the RSV current outbreak seems to have peaked around the end of November. The influenza part of the Tripledemic peaked around mid-December. And COVID is still rising at the moment. So they didn't completely line up, but they were very close this year, which I think has probably contributed to some hospitals seeing more. And to answer Dr. Perez's question about why we may see that people are getting less sick with COVID now, particularly compared to 4 years ago, which it's been a long 4 years.
Yes.
One answer, and I think the best answer, would be that immunity works, or at least it helps. Every person walking around now has probably been vaccinated, infected, or some combination of those two multiple times. And immunity does have a very nice shielding effect. And if I could go into my body and tell my immune cells, hey, this is the virus, you want to recognize it, and you want to make a good defense against this, I would do that. And I would probably be completely immune. But there isn't a good way to do that other than vaccination. The immune system is made of a bunch of cells that are really not connected to each other. They just communicate at a distance. and they do their best, but vaccines are really the only way to get through to the entire group of them, which is what you have to do.
Thank you. So we end our discussion here. Thank you so much to all our reporters for joining us today. And we'll see you next Friday. Take care.